Hello friends, this is Nishant. I am here with the next video on ECG, and in this video I want to talk about T wave and U wave. So if we draw a normal beat of ECG, this is a P wave, this is a QRS complex, and this is a T wave, and this maybe is a U wave. So in this video we are going to talk about this area and this area. Now the ECGs and diagrams that are used in my video were borrowed with permission from following two websites, ecg.utah.edu and ecglibrary.com. These two are very good websites if you want to practice additional ECGs or learn about them in detail. Let's talk about T waves. T wave denotes ventricular repolarization and is normally a smooth upstroke and downstroke. So normal T wave looks like this. If you see any notching or any disfigurement of T wave, that is probably due to a superimposed P wave or a U wave. Now, what other abnormalities are seen with T wave? Number one is T wave inversion. So, if you are getting symptoms of suggestive of myocardial ischemia like chest pain, shortness of breath, chest tightness, or chest pressure, and you see a inverted T wave, you should do aggressive workup to figure out the cause of symptoms. It is very likely that the symptoms are due to myocardial ischemia, and a timely intervention can save life of the patient. Then there are non-specific changes in absence of symptoms, that is most of the times they are inversions, that is seen in LVH and RVH, that is left ventricular hypertrophy and right ventricular hypertrophy. It is also called as strain pattern. Then there is something called as flattening of T wave that is seen again in myocardial ischemia, although this is not very common. Then tall peak T wave, those are seen in early myocardial infarction and in hyperkalemia. So they are also called as hyperacute T waves, and they are the first ECG marker of myocardial infarction. Alright, let's move on and see few ECGs. Let's have a look at this ECG. I want you guys to focus on T waves. Now you can see T waves are tall in lead V3 through V4. They are tall peak T waves. So what are some causes of tall peak T waves? Number one is acute MI and number two is hyperkalemia. So how to differentiate them? Acute MI most importantly will have symptoms, clinical symptoms, and hyperkalemia generally has broad QRS. So we have seen this ECG before as well with respect to broad QRS. So if you see a broad QRS with tall T waves, that is mostly suggestive of hyperkalemia. So this ECG is most likely showing changes associated with hyperkalemia. Let's have a look at next ECG. I'll take a 1 second pause. Alright, so most of you I'm sure have identified it correctly that this is T wave inversion in lead V5 to V6 and probably in lead 2 and 3 and AVL as well. So what are some causes of T wave inversion? Number one is, and most alarming one, is subendocardial or myocardial ischemia. Number two is LVH and RVH. So if I tell you that this is a 30-year-old man with no symptoms and uncontrolled hypertension since last 5 years, you will probably tell me that this is the diagnosis. However, if I tell you that this is a 75-year-old lady with a multiple comorbidities like diabetes, hypertension, CKD, with symptoms of chest pain, you will probably pick this one. So the one take-home message that I want to give you guys is, you treat a person and not an ECG. Of course, ECG is important as it gives a lot of diagnostic clues, but looking at symptoms and signs is more important. ECG just supplements the diagnosis. Moving on to the last part of my lecture, U wave. So U wave basically they probably denote repolarization of His-Purkinje system or late ventricular depolarization. And it is important to remember that U waves are seen in chest leads. So how they look basically is, if this is a T wave, then you will probably see a U wave like this, or if this is a T wave, you will probably see a U wave after that. So they are seen in hypokalemia, congenital long QT, and sometimes as a normal variant. Let's have a look at few ECGs. I want you guys to focus on chest leads only. Now you can see that in this ECG, this is Q wave, this is R wave, there's no S wave, then there is T wave, and then this is U wave. Now the positive deflection of immediate positive deflection after T wave is a U wave. So this is an ECG of hypokalemia. Alright, let's move on to the next ECG. Let's look at last ECG for this lecture. So in this ECG, I want you to start marking the waves. This is a P wave. This is a small positive deflection, that is R wave. This is the large negative deflection, that is a S wave. This is a T wave. And this wave that you are seeing immediately after T wave is a U wave. Then again, this is a P wave. So U waves can be slightly harder to identify, but once you get used to reading the ECGs, you will be very comfortable in identifying them. Thank you so much guys for watching my video. If you like my video, please subscribe to my channel. I will be posting series of videos on ECGs and other topics in upcoming weeks. If you have any questions, concerns or doubt, please feel free to reach me at love.intmed@gmail.com. I want to thank Dr. Frank Yanovich of ecg.utah.edu and Dr. Dean Jenkins of ecglibrary.com for allowing me to use their ECGs. Then I want to thank two of my best friends, Dr. Pranav Patil and Dr. Aditya Tolat, for their valuable inputs in designing and modifying this presentation. Here comes the mandatory slide. I like to conclude all my presentations by the next slide, by remembering the motivation for me to come in the field of medicine. My uncle, late Dr. Sanjay Tiwari. I used to call him Dr. Chacha. I just want to give him one message, that whatever I am is because of him and he is being missed every single day. Thank you so much guys, and I wish you good luck.